precision grip? Yes, what is our way to remember precision grip?
Paper test?
The paper test? I like the thought. The classic prone paper test is for the ulnar nerve to put it in between these fingers, but if you were to do it like that, yes, I like it. But precision grip comes because we have our loaf muscles. So our first and second lumbricals and the femur muscles. We recall maybe. So you holding your pencil like this is all median nerve. So we lose buttoning the shirt, those kind of things, or we have difficulty with them. So once again, direct pressure, that's our compression, typing like this, all that kind of stuff. All of our tests are going to replicate that for the median nerve. We're going to push them together, we're going to do this, we're going to whack them with a reflex hammer, see if you can reproduce it. But fluid retention, so pregnancy is first one, rheumatoid arthritis, we see it a ton with, diabetes, connective tissue disorders. So all things that are going to cause more fluid retention with it. So the only treatment that is you just have to do, like absolutely have to do, they're going to benefit from a lot of things, but splinting at night. Because if you can reduce that inflammation to that nerve over and over again every night, they're not going to have that, and during the day they don't suffer nearly as much. So night splints, they do phenomenal with adjusting, but if you adjust them and they go like this for 8 hours every night, you're fighting an uphill battle. And then surgery, if they don't do well with adjustments, they've come a long way with surgery for carpal tunnel. So if they do not respond well, and not to one adjustment, you're treating them for quite a while. Before we go on, yes?
How would a wrist splint reduce their inflammation?
Because we have, if they're sleeping like this, like most people are going to bend their wrist at some capacity. If they don't, it's not going to change it. But the idea is you're going to keep that at a neutral position so you haven't narrowed the carpal tunnel region. Okay, what is our major red flag of all peripheral neuropathies? Before we miss it, what's the one thing that you say, this isn't my patient? What do they all have in common? There's only one scenario. All of them you should be treating, and they will, almost all of them are going to do phenomenal under care. What lower motor neuron lesion sign says, oh crap? Babinski's upper motor neuron lesion. Not hypotreflexia. Hypotreflexia is fine. You'll all see it all the time. What is our huge red flag with peripheral neuropathy? Yeah, atrophy, absolutely. So atrophy, if you were to see that in any muscle, especially if they're like, hey, this happened 2 weeks ago and you can now see that atrophy, not that you can't treat them, but you are immediately co-managing. You should help them, you should treat them, but they need a surgical consult today. Today. And if not, that is your license on the line, because legitimately in a week that could be just hollowed out, and they're not getting that back. So you don't mess around with atrophy. Once again, I'm encouraging you to treat them. I would not send that patient out, but I would also get them an appointment today somewhere. You call, you help them out, because they just won't have good function of their thumb in this scenario for the rest of their life. Alright. Atrophy. Alright, pronator teres. So we have the two heads of the pronator teres, the median nerve goes through it. If we compress that, we are going to get entrapment of the median nerve at the elbow here. So with this, we're looking at all of those same signs and symptoms that we get with the wrist, but once again, it's coming from this elbow region rather than the wrist. We have one thing, if we go back, there's a bunch of ways to tell the difference, but we have avoids the carpal tunnel, it goes over it. So with carpal tunnel syndrome, you will not lose sensation in the palm. In pronator teres, down here in the elbow, you absolutely will, because it's proximal to that branching of that nerve. But you'll notice they usually have pain in that forearm region. If you push in that general area, you can recreate the pain. But all the rest are going to be very similar symptoms. Very, very similar. Alright, cubital tunnel. The cubital tunnel syndrome is right here. So this is our funny bone. You whack your funny bone, it hurts. We all hate it. But now your patient has that all the time. And just that horribly annoying sensation. So what gives us the cutaneous branch to just our forearm? Yeah, medial antebrachial cutaneous. So that is not the ulnar nerve. That branch is much higher up, because that branch is off the cord. So you are not affecting this. But what do you feel going down your forearm? Yeah, the tingling sensation, exactly. But you did not lose any sensation here. It feels weird, you don't like it, but the sensation would be lost only in the ulnar nerve distribution area, not in the antebrachial, medial antebrachial cutaneous area. What we will see other than that is these ulnar nerve muscles weak. What does the ulnar nerve primarily do? Power grip, yeah. So the majority of our flexors associated with our hand, as well as adduction and abduction. And then you'll see the lumbrical. So the third and fourth lumbrical here. We talked about some tests here. So Wartenberg sign, if you put your fingers up like this, I have a perfect Wartenberg sign. This finger right here goes out. I'm trying to put them together like this one. You got one, two, you got two. I like it. But that's compression of the ulnar nerve right there, specifically at the wrist. It's just one of the classic signs we see.
That's when you can't.
There are things that can rule that out, right?
What's that?
There are things that can rule that out.
Rule what out?
Rule against that. Because like, if you look at my, like, I have a block, right? So I can't, like, if I just do that naturally, that's wider, but then the hip, that fits better.
Absolutely. 100%, yeah. So you always want to follow that up with, is there any history that would make that true, or make that not true? We also have Fromm's paper signs. You guys do this in orthopedics. You just put paper in between their fingers and say, hold on to it. If they can't squeeze it, then it's a classic sign of an ulnar nerve entrapment.
I was confused with that last one. That was, so this one you said was just Fromm's sign?
This is Wartenberg's.
Wartenberg, and why is it just, were you doing it on purpose with the one hand out?
No, I'm trying to put them all together. I have it positive on this side.
Okay.
So that's,
and that would be lumbrical weakness?
that's the ulnar nerve.
Ulnar nerve?
So yeah, ulnar nerve compression or damage at some point. Okay, so our best test though for cubital tunnel syndrome is, I gotta move this out of the way so I don't trip on it for the sixth time, is flexion of the elbows with compression. So it's a mixture of these. I don't know what's happening down here. I hope you guys can see it. But flexion of the elbows, and you are actively compressing in that region. If you can't recreate that pain, it's not coming from the elbow. It's statistically a phenomenal test, but you're just once again compressing that region and pushing there. You can also just whack it with your hammer. You got options. We're going to make this simple in 1 second, but they're piling on a little bit. So, tunnel of Guillain, still the ulnar nerve. So it branches, it goes from our cubital tunnel and goes down through the tunnel of Guion. We see that right here. So we could have compression, and this is how the ICD-10 codes everything. You could have compression of the median nerve at the wrist or the elbow. You have compression of the ulnar nerve at the wrist or the elbow. So we don't need to horribly overcomplicate this, but we call it tunnel of Guion for the ulnar nerve at the wrist, cubital tunnel for the elbow, just where it's physically going through. It's all the same tests, but you're just noting, do they have that zinger sensation down? If they can feel that zinging sensation down, where's the issue? The elbow. Yeah, they're not going to have that when it's at the wrist. It's our best way to determine the difference because the signs and the testing are distal to that. So it is a good way to go about that. All right, radial nerve. So we said 2 nerves of the body give us motor symptoms before sensory system symptoms. We got the radial nerve, so we get wrist drop. What was the other one? For motor weakness, what do we get for motor weakness before sensory loss? It's wrist drop, or it's another thing dropping. Foot drop, yeah. So wrist drop and foot drop are the 2 that produce motor symptoms before pain and paresthesia. So with honeymooner's palsy or Saturday night palsy, so honeymooner's palsy, the idea is you're cuddling, you got your arm around and you've compressed that the radial nerve. The Saturday night palsy, you drank too much and you fell asleep on a park bench and you've compressed that ulnar nerve, so radial nerve. So in both these scenarios, we mostly talk about the spiral groove, if you can recall from your osteo days, that are pushed on right here, and we just lose that sensation. We lose that motor function. If we see loss of sensation or pain and paresthesia, we classically see it on the dorsal web of the hand, just like we looked at with chiralgia paresthetica. So our dorsal web of the hand. Alright, we also have pin or the posterior interosseous nerve. So our radial nerve goes deep and becomes our posterior interosseous nerve. Just like our median nerve goes deep and becomes our anterior interosseous nerve. So with this, a lot of the exact same symptoms here. You're going to classically see this from an overuse injury with extensions. So you look at like factory workers and other things that just have a lot of repetitive motions over and over again. But once again, this is a deep activity, so there's only motor weakness. Classically just test it by pushing down on the middle finger here. But pronation, supination type motions with extension. Alright, sciatic radiculopathy. So we could have sciatica. Sciatica is a general term. It could be where have we compressed the sciatic nerve. If you say sciatic radiculopathy, we have compressed what? The where? The root. Yeah, the nerve root. So we know that the sciatic nerve goes from L4 to S3. So in theory, you could have compressed any of those, but it's almost always L5 and S1. But when we look at this, we have, what's our most common reason for radiculopathy? Yeah, disc herniations. The disc herniation hits that sciatic nerve. The sciatic nerve does not innervate any muscles, nor does it go and innervate any cutaneous skin. It does nothing. Except for it branches into everything else. So it branches into our, what 2 nerves? Tibial and common fibular. Good. So because of that, depending on where you've compressed on that nerve, you can see a whole host of weird stuff. But with a radiculopathy, you follow our dermatomes, and you follow our myotomes, so the muscles that are associated with that, which I'm not asking you to have all those down because you guys will be forced that down your throat in 2 quarters. But we just know we're going to have motor weakness and we're going to have sensory loss. So what is the lowest reflex in the body? The Achilles. Yes, the Achilles is associated with S1. So S1, Achilles loss with sciatic radiculopathy or sciatica is almost expected. So you check one side, you get a nice reflex, you check the other side, and it's decreased or absent. It should be something that you note on the majority of your sciatic radiculopathy patients. And then you're going to have some paresthesia in some position, and then some motor weakness as well.
Would that be an ipsilateral side as where the Achilles is not?
Absolutely, yes. So whatever side they have that compression on, it's just distal to that. Yeah, so you would compare it from the healthy side to the affected side. Piriformis syndrome. So piriformis syndrome is compression of the sciatic nerve again, but we've compressed it in between the piriformis muscles. The majority, the other 90% of people, their sciatic nerve goes under or above the piriformis. If it goes through the piriformis muscle, we talk about piriformis syndrome. So what does the piriformis, what's the action of the piriformis muscle? What does it do for external rotation? Exactly. So if someone has their leg externally rotated and that piriformis muscle is tight, it's a good indicator that that could be what we're looking at. But the reality of this is, what's the big difference between sciatic radiculopathy and piriformis syndrome? Where is their local pain? Yeah, at the piriformis or in the low back. So if it's a radiculopathy, they have low back pain. If it's piriformis syndrome, they got butt pain. So that is the major differentiator, and you would try to recreate that pain with an orthopedic test where you just internally rotate the leg. That's all you're doing.